later. Great. So we're recording now. Okay. So the idea here that I've been in Erbil, so welcome every day. Please don't text me because I'm too busy to answer the text. So if you want to say something, open your mic and talk to me. Please don't text me because I don't see the text. I will be busy presenting. Okay, I don't have moderator. So please, kindly, not text. When you need something, just talk to me. Okay, open your mic and talk to me. I can stop and then answer whatever you need. So the idea here, since I've been in Erbil, I saw like there is a gap or deficiency in two areas, intensive care, whether it's NICU or PICU. And also I saw some defect in rehabilitation, but I guess you guys are not interested in rehabilitation. Okay, so we'll start with a general topic, acute care of ill child, and also we'll take later on acute care of newborn. So acute care of ill child, let me ask, and I was surprised that some of you don't, not of you, but the doctors that I met, they don't know some principles of like a medical term, and probably they assume they know, but they don't. So let me ask you before we start, what is ill? What does ill mean? Or sick? What is sick or what is ill? Anybody want to answer? I need you to chat with me. Any idea? Guys? What is ill?
Victoria,
What is
Yeah,
sick?
doctor.
Victoria,
Go
Victoria,
ahead.
anybody join the meeting?
Yeah, everybody is joining, Dr. Zuhair.
Really? Good. So,
Like we have 25 participants. Okay,
right.
so what is ill? Anybody?
Good luck.
Ill means suffering.
Oh, a child that is suffering.
While
Okay, so that
sickness means affecting the physical and mental activity.
okay, so a sick will affect your activity. Yeah, that is ill. So ill, you are ill when you cannot perform your activity. That is ill or sick. Sick not mean a disease, or so you can be sick but you don't have disease. So ill is a child who cannot perform his activity. So if he's a newborn, he cannot suck, he cannot sleep, he cannot cry. And if he is like a 6 years old, he cannot go to school, he cannot like go to the bathroom. So that's what we mean by ill. Okay. So when a child is ill, usually it originates from three. When the child becomes sick or ill, or pending problem, the problem either respiratory or circulating, or it's the heart. And from respiratory, we already have a respiratory distress. Distress means a child who's using extra effort to do the gas exchange. Or you go right away to failure. You guys see my mouse or no?
Right. It's clear.
Yes.
Yeah. So a respiratory failure is different from distress, is when the lung fail to do the gas exchange at the level necessary for life. So we fail, because that's why the respiratory failure definition is not available. There is no reference to what is failure. That we don't know what is the failure, because failure when you are not on a support is different from failure when you're a support. But failure, in short, is when the lung failed to provide gas exchange enough to survive. So you either go from respiratory problem to respiratory failure right away, or you go to distress, which means you have you're suffering, to go to failure, and then you affect your heart and you get cardiorespiratory failure, and then you end in cardiac arrest. Failure of circulation cause shock, and then we will know what is shock. Also cause cardiorespiratory failure and then cause cardiac arrest. However, arrhythmia sometimes can cause one of the arrhythmias cardiac arrest, and sometimes is arrhythmia and then go to cardiac arrest. So ultimately your heart stop beating. Okay, now cardiac arrhythmia is rare in children. Cardiac arrhythmia or abnormal rhythm to cause cardiac arrest is very rare in children. It's less than adult. And if it happens, it's usually either VF or VT, cause cardiac arrest. So we have respiratory, circular, and sudden cardiac arrest. Respiratory problem, as we said, may progress to failure with or without respiratory distress. So be careful when you deal with children. You might go right away to respiratory failure without distress. Now, respiratory problem without respiratory failure without respiratory distress can happen from the upper airway and can happen from lower airway. It's most of the time respiratory failure right away without distress happen when the child cannot open or fail to maintain open airway. Now we will talk later what is upper airway and what is lower airway. Now, if you guys have taken the PULSE, which is pediatric advanced life support, that you will be trained that you'll do your initial impression. And the initial impression for any child is you look, is the child conscious? And you have to know what is definition of conscious. Is the child breathing? And what is the color of child? Now, from these three questions, you will decide, is the child unresponsive or the child is responsive? So you go initial impression, you go to a child who crashed in front of you. You look, is the child conscious? And then we will talk later what is conscious. Is the child breathing or not? And what is the color of the child? Like, is the color pink or not? Now, if the answer is yes, after your initial, you will decide, is the child responsive with breathing or not responsive without breathing, or not responsive and only gasping, and then also later we'll decide what is gasping. So if your answer is yes, the child is unresponsive or not breathing or breathing with gasping, and we'll define gasping later, then the first thing you will do is shout for help, because one person will not able to manage this baby. After you shout for help, or if you have alarm or code in your hospital, you have to activate the code. Or if you don't, now it depends on the age. If it's newborn, you will activate neonatal code, whether it's pink or blue, depend on the hospital, or it's a pediatric code, or you shout for help simply. After you shout for help, you go right away. There is pulse or there is no pulse. If there is pulse, you concentrate on the airway. Is the airway open? If the airway is open, you start right away to ventilate and give 100% oxygen. If the child if there is no pulse, you go with CPR. Now, before in children, we call it ABC. So airway, breathing, and circulation. Now this change to CAP, where we start with circulation, then airway, then breathing. And if there is no pulse, you go right away to the cardiac arrest algorithm. And you continue for that until you regain your consciousness. Once you go to regain your consciousness, you activate the circle of evaluate and identify, intervene. Now, if there is pulse and you start ventilation or respiratory support and you start oxygen, then after that, check your pulse. And when you check your pulse, you don't need to count accurately. You just need to say your pulse less than 60 or it's more than 60. If it's less than 60, even if there is pulse, you go to the cardiac arrest or you go to CPR. If it's more than 60, then you go to your routine of evaluate. Remember your routine, evaluate, identify, intervene. Now, evaluation are composed of 3 parts: primary assessment, secondary assessment, diagnostic test. Once you assess, you identify your problem. And then once you identify, you intervene. And then you evaluate again, identify, intervene. And believe it or not, in intensive care, diagnosis is not important. Identifying the problem and managing them is what we do. Not important, but not as important as identifying the problem. So let's make it short. You go, check the consciousness, check the breathing and color, and then decide, are you conscious or not? Are you breathing or not? And if you're breathing, are you gasping or not? If yes, shout out for help, check the pulse. If it's no pulse, do CPR. If there is pulse, give ventilation support, whether invasive or non-invasive, give 100% oxygen, check the pulse. Less than 60, do as if it's arrest. More than 60, do your routine of evaluate, identify, intervene. Till when you continue your CPR? Until you regain your consciousness. Once you regain your consciousness, do evaluation, identify, intervene. Now, is that clear? Any question, or I did confuse you?
No, it is a beautiful presentation.
It's
It
clear,
is clear.
Judge.
Yes, clear.
Ask. Great. Okay. So, when you do your pediatric advanced life support, you have to do it quick. You need also to do your initial visual and auditory observation. Is the child breathing? Is it noisy? Is it pain? Like quick. When you initiate and when you start to assess, you do your consciousness, and you don't need to go to details of consciousness. You just need to say 3 things. Is the child unresponsive? Is the child irritable? Is the child alert? And when you assess your breathing, you just need to say, is there is increased work of breathing? Or there is absent or decreased breathing, apnea or hypopnea? And if there is abnormal sound, you don't need to auscultate even. So you do it that quick. Okay, so remember our initial impression was consciousness, breathing, and color. So consciousness, you need to do, when you go initial impression, you answer, or after you assess, your identification is unresponsive, irritable, alert. Your breathing, the baby is increased work of breathing, baby is not breathing, baby have decreased breathing, and there is abnormal sound, noise or guggling or burping or crackles, whatever you hear. So remember, you said consciousness, breathing, and color. For color, you just need to say three things. Is it cyanose? Is it pallor? Is it mottling? So that's your initial consciousness, breathing, color. Okay? Now remember the causes of unresponsiveness or decreased consciousness. Either you are deficient of oxygen, or you are deficient or inadequate substrate, sugar, or you have a trauma, or your brain is not functioning, whether there is injury or there is toxication. So what is abnormal breathing? Abnormal breathing is you are using accessory muscle. There is sound, and their breathing pattern is abnormal. Now, here is very important questions, because people confuse between grunting and breathing difficulty. So I'm gonna ask you all, what is grunting? Because some people think that moaning, like this is grunting. Okay, so anybody can answer me, what is grunting?
Pediatrician,
Sorry, Dr. Zuhair, what's
Anybody?
grunting?
I leave this to the pediatrician. Anybody?
Anybody want to answer me, what is grunting?
It's a noisy breathing sound due to
Yeah.
the
It's a
eagerness to
noisy
the
breathing sound.
Yes, due to the eagerness to oxygen.
Okay, so if you look here, Dr. Diyar are talking, right?
No, Dr. Sarah, but the name is wrong.
Okay, so Dr. Sarah, you can see here, when we look at abnormal breathing, we said use of accessory muscle, extra sound,
Yes.
and breathing pattern. Which
Yes,
one you think? Which one you think grunting is belong to these three?
extra sound of the breathing.
Extra sound is grunting. Okay, anybody else? Anybody else know what is grunting?
Dear
No?
doctor, it's a short, low sound.
It is short what, Dr. Tafja?
It's short. It is short, low sound. That means using of accessory muscles.
Okay, so grunting is use of accessory muscle. Anybody else?
Yes.
Dear doctor, a grunting is the body finding a way to try and keep air in the lung. Plus, which is a expiratory
that
noise
is-
which made by neonates that having
No,
a respiratory problem.
You were right at the beginning and then you were wrong at the end. Okay, anybody else? You see, it's sometimes a very serious problem that not only you, many pediatricians, not only in Iraq, they don't know what is grunting because they think that grunting is respiratory difficulty. Or some people think that grunting is a noise. And some people think the grunting is accessory muscle. Grunting, when we say grunting, we're talking about the breathing pattern. Okay, so how we human being breathe? We breathe in, and then we breathe out, and then we pause. Why? Because God, Allah, created us with surfactant in our lung. There is fat in our lung. So we knew that our lung will never collapse. So we breathe out, we breathe in, we pause, we speak, and then we breathe out. Okay. So when the child starts to grunting, okay, he lose the surfactant or she lose the surfactant. There is no fat. So when the air goes out, the lung will stick. So what the human body did, reverse the pattern. So they start to breathe out and then breathe in and then pause. So that's how we breathe normally. And then we rest. Look at the grunting. We breathe out. So we pause when our air is in. So when we say grunting, that's mean two things, two possibility. Surfactant is not there or surfactant are deficient. Either we have RDS or we have adult RDS. So grunting is not noise. Grunting is not respiratory difficulty. Grunting is abnormal. Grunting is not moaning. Okay, these are not grunting. Grunting is reverse of respiratory cycle. Instead of pausing after exhalation, we pause after inhalation. Now, is that clear? Answer me.
Yes.
Yes, yes.
Okay, so when we say respiratory difficulty, we're talking about increased work of breathing. When we say grunting, we're talking about surfactant deficiency. Now, we have RDS, we have congenital RDS, and we have adult RDS due to many factors, infection or inhalation or whatever, or crash injury, whatever the reason. Now, is there any question? So use of accessory muscle mean increased work of breathing, presence of extra sound, okay? So what is the normal sound of a human being? When we breathe, what is our normal sound? Talk to me. You need to chat with me. Don't feel shy. What is our normal breathing sound? What we call it and why? Nobody? Answer me.
Vesicular sound and bronchial.
Vesicular sound. Great. So the normal is vesicular sound. So what is vesicular sound? Is that Zela? Zela? Is that how I pronounce your name?
Gila.
Gila, thank you. So what is vesicular sound? Now let me explain to you what is vesicular, because that's very important. I know people are confused. Now the origin of any sound is our larynx, is not our lung. Now imagine if I knock on the table and you sit beside me, you'll hear my knocking. But imagine if you put your ear on the table. What is the difference in your hearing between when you hear and you are not on the table, your ear not on the table, and when your ear on the table? What is the difference?
There will be vibration.
So when you put your ear on the table, you hear more sound because
Yes.
in solid sound transfer very quickly. So when you put your ear on the table and I knock on the table, you hear very loud. But when you put your ear away from the table, you not hear loud because there is between the table and your ear, there is air, and the air filter the sound. Is that clear? So that what happened. If you put your stethoscope on your larynx, you will hear the sound right away from your larynx. When you put your stethoscope on the chest, you hear the sound as if you're hearing when I knock on the table. When you put your larynx, your stethoscope on the larynx, you're hearing as if you're putting your ear on the table. The difference is filtration by ear. So that vesicular is filtered by the lung. Now the sound you hear it when you put your ear on the table or you put your stethoscope on the larynx, that's called bronchial breathing. Okay, do you understand?
Yeah.
Yes.
Yes.
Great. So now imagine you don't have lung. What you will hear? You hear as if you are on the table. Now, what are the possibility that you don't have lung? Because lung mean alveoli, right? Which diseases cause absence of alveoli? Pneumonia. So when you have pneumonia, when you have solid, as if And when you put your stethoscope on the lung, as if you are putting your stethoscope on the larynx, because there is direct connection between the larynx and the lung, because there is no air in the lung. There is the alveoli is filled, inhabitant, with something else. Now, do you understand what is a bronchial sound?
Yes.
Do you understand what is vesicular sound?
Yes.
Great. Now, when we have extra sound, anything other than vesicular and bronchial. So we have bronchi, you have crackles, and breathing pattern. We've talked about one of the breathing pattern is grunting. We have other types of breathing pattern we'll talk about. Now, any questions so far? Guys, questions? No question.
Dr.
Now-
Yahya, Dr. Yahya, the bronchial breathing only in consolidation? Only pneumonia,
Yeah.
or you can
No,
get it in other
any
causes?
any direct connection between the lung and the larynx without air presence. Now, anything to replace the normal inhabitant of the alveoli and the airways, which is the air, replaced by something else, is causing bronchial breathing.
Doctor, what about lung collapse?
Collapse also causes.
Anything
Yeah.
to replace alveoli, normal inhabitants of the alveoli. Anything. Okay? And what caused muffle of sound when your stethoscope separate from the lung, you don't hear the sound. So that's a different story. But if you have a blood, if you have a fluid, if you have collapse, if you have mass, if you have vessels, anything replace and connect you directly to the larynx, you hear bronchial breathing. Now, I'm going to these details because I know some people are deficient with it. Now, I'm not saying that you guys don't know, but I'm trying to give you the principles when you deal with a baby, you know, in details, what exactly you're expecting. Now, we've talked also, and then I'm going to stop here, but I'm going to ask you another simple questions, and you guys will be surprised you don't know the answer. What is upper airway and what is lower airway? I'm going to invite you on a heavy meal if you know the answer.
The lower airway
Anybody?
usually connected to the alveoli, isn't it? It is the upper airway is only it is only a passage of the air, but
Okay,
the
upper
lower
airway is only passages, and the lower connected to the alveoli. That's your opinion, Dr. Zuhair. Any other opinion? If you know the answer, I'm going to invite you to a heavy
The
meal.
lower airway from the bronchial. Lower airway is from the bifurcation of the bronchial downward.
Okay, so the Shara is saying that the lower airway is anatomical demarcation. Anything lower than the bifurcation is lower airway. Anything above the bifurcation is upper airway. I'm saying it right? That's your opinion?
Yes. Yes.
Okay, any other opinion?
Dear doctor, upper airway, including nose, mouth, sinuses, pharynx, and including larynx. Okay.
And anything below the larynx
But the
is lower airway.
airway. Below the larynx, trachea, bronchial, and downwards is lower airway.
Okay, so Tom just saying it's anatomical demarcation of the larynx, upper and lower. Any other opinion? Any other opinion? I'm very disappointed. You don't share. That's very, very important to share, to think. Otherwise, you won't be able to be intensivist. You have to think and talk. Any other opinion?
What we call the bronchioles, the lower one.
Yeah, but so you're saying that anything connected to the alveoli, any airway connected to alveoli is lower airway, and anything not connected to the alveoli is upper airway. That's your opinion, right, Dr. Zuhair?
Yes.
Yeah. Any other opinion?
And
The an-
so it's
yeah, go ahead, Media.
يعني anything below trachea it is regarded lower respiratory
Okay, so it's
part.
anatomical position above and below trachea, isn't it? Is that your opinion? Okay,
Yes.
so unfortunately, all of you are wrong. Unfortunately, all of you are wrong. And that's why it's important to know
No,
these
no
things, details.
invitation. No dinner.
No, unfortunately. I know if
Okay.
you if I knew that you will know the answer, I will not say that. Okay, so I knew that you will not know. So upper airway is when the pressure is positive. Upper airway is any part of airway passages surrounded by atmosphere. And lower airway is the part of the airway that's surrounded by negative thoracic pressure. So it's not anatomical demarcation. It's actually movable up and down during breathing. So upper airway is surrounded by
functional.
positive, and lower airway is surrounded by negative pressure because it's surrounded by thoracic cage. And why this is important? Because for air to move from point A to point B, I might disconnect at any time because my Zoom is free account. But I'm gonna stop here and concentrate on this point. For air to move from point A to point B, the point A should be higher than point B, so air can move. Okay, so imagine that we are breathing in, and the point A is the atmosphere, and point B is your mouth or your larynx. So what is the pressure in point B should be? Which one is higher, B or A? Now imagine A is the atmosphere and B is upper airway. And the pressure to move from A to B, which one is higher?
Should be
Any
higher
answer?
in the larynx. It
Yes,
should be
no,
higher
the
in the
higher
larynx.
should be in the air. For the air to move from A to B, the A should be higher than B. So the air to move from outside to your mouth, your A, which is atmosphere, is higher than B. And that's why the atmosphere will compress your upper airway. And that's why when you have inspiratory problem, we say it's in the upper airway, because the lowest diameter of the upper airway is during inspiration. Why? Because A is higher than B. Do you understand?
No.
Yes.
Now, for the air to move from the mouth to the lower airway, B should have, and then if we say lower airway is point C, B should be higher than C. Okay?
Right.
So how we
Right.
increase the pressure in how we increase the pressure in C, in the lower airway? What we do to increase to decrease the pressure in C. So B should be higher than C. So what we do to decrease the pressure in C, so B is higher. What we do?
Decrease air.
We decrease the negative pressure. We decrease the pressure inside the chest. Okay, so we can expand our airway. Okay, so we decrease the pressure in the cage, then the airways will expand, then the pressure in C will decrease, and the air will move from B to C. And that's why the widest diameter of the lower airway is during inspiration. So the lowest diameter of the upper airway is during inspiration, while the widest diameter of the lower airway is during inspiration. Now, for the air to move from point C to B, C has to be higher than B, isn't it?
Yes.
So how we
Yes,
do?
from high
We
pressure to low
compress.
pressure.
Yeah, so we compress our airway. So we can increase the pressure in C, so the air move back to B. So once we compress, we get a smaller airway. And that's why the lowest diameter of the lower airway is during expiration. And that's why we have when we have a lower airway, we get expiratory problem first. Now for the pressure to move from point B to A, B has to be higher than A. Correct?
Yes. Yes.
So if the
Yes.
pressure in A, which is inside the airway, will push the airway outside. And if the pressure in A is lower, then it will push or pull the airway out. And that's why our widest diameter of the upper airway during expiration. And that's why we will never have a problem, or rarely have a problem, expiratory problems, upper airway. Now, so go back to the problem. Upper airway, inspiratory problem, lower airway, expiratory. Where is the lower airway and upper airway? Is the thoracic inlet. That is the demarcation between. And thoracic inlet is moving up and down. And what is thoracic inlet? It's from positive pressure to negative pressure. Now, is that clear?
Almost.
Now, for the color, we have pale, mottled, bluish, gray. All of them suggest either poor perfusion, poor flow, poor oxygenation, poor exchange, or both. If we are flushed and we have lots, we have vasodilatation, then it's either fever or toxin. Now, I think I have to stop here before I go to evaluate. So now I finished initial evaluation. So now I decide consciousness, I decide breathing or not, and I decide the color. Now, what is gasping? Anybody know what's gasping? We always use this term. And then I will stop. What is gasping?
Reverse of the respiratory cycle?
No, reverse of respiratory cycle is grunting, not gasping.
Yes, yes, yes.
So what is gasping? بالعربي شو يسمونه؟ من يعرف؟ gasping.